She says, no, I think it's 2 o'clock, so, I guess I better get ready. But we made it.
Yeah, you did.
Proud of you.
And Josh is gonna be our speaker today.
Howdy, everyone. I know a lot of you. I'm the director of lifestyle medicine, so this clinic, all of our lifestyle medicine clinics, so including down in Magic Valley.
Wow.
So
Do they have a cardiac rehab in?
yeah, so we have 3 cardiac rehab locations. So here, of course, is kind of our flagship right here, and then Magic Valley, so Twin Falls. So they've actually had a cardiac rehab program there for about 10 years.
Really?
So kind of in the beginning, it was kind of loosely affiliated with us, and then over the years has come into the fold. They started initially as kind of a closet or shared space in the hospital with physical therapy, and then eventually kind of got their own clinic down there.
Cool. No, the wife and I grew up down in the Rupert area and lived in Twin Falls for a while when we were first married, so we like Twin. Other than the wind blows a lot more than it does here.
Yeah. And then our 3rd clinic is out in Nampa. That's our newest clinic. And then from volume standpoint, Twin Falls is probably our smallest, and part of that is just limited from size. And then Nampa's been growing pretty steadily over the years too.
Is the clinic as complete over Nampa and in Twin Falls as it is here?
Yeah, kind of same pretty much size footprint from a gym standpoint down there. It has a nice walking track. I would say when you look at it, the size-wise is about the same. When you look at it, it looks bigger, I would say. And then currently we share our clinic space with kidney and hypertension, but they're supposed to move out in this fall there. And I think across the board we're seeing bigger numbers, and that's just because I think overall, in the hospital, they're seeing more stents placed, they're seeing more open hearts done, they're seeing just more procedures overall, and that's probably just a result of just the growing population to Idaho, and that population tends to skew a little bit older too, that are coming into the state here too. So.
And are the numbers of doctors coming in here, cardiac doctors, is that keeping up with the pace of the population? We've got new docs?
Yeah, at least in the Treasure Valley, we've had a lot of new docs within the past couple of years, and kind of pretty young, innovative, bringing new programs to the valley as well too. Twin Falls is a little bit of a struggle from a recruitment standpoint. Not as many people want to move to Twin Falls as they do to Boise.
Because one of the Twin Falls does only AFib, or what are they involved in any open heart?
No, from a procedure standpoint, the only sites that do open heart and any structural like a TAVR, transaortic valve replacement, is at the downtown. So nowhere else does it. They just do stents down in Twin Falls, and that's kind of, in Nampa they're not really doing any interventions right now, and that's just because of some staffing issues, and some other things. But I think the plan is to resume stents out in Nampa, but it's probably going to be a long-term plan out there.
Do you see your operation, I'll give an example, St. Luke's and St. L's both do cardiac work. St. L's is developing a program in Baker. Do you guys see, because of the fact that you've got such a wide geographic area, that you bring patients into this downtown area from all over? Do you see, in the horizon in the next couple of
Probably not, at least from not a cardiac rehab. I think the thing that will probably be more impactful, there's been legislation kind of proposed for pre-COVID, but kind of COVID sped it up. But there's a big push to do virtual cardiac rehab or home-based cardiac rehab, because, you know, we know that there's people that are coming and having their intervention at one of these kind of specific sites down here, then they go back home to, you know, they're going to Weiser, they're going to McCall, they're living in Parma, they're in Wood River, and they don't wanna drive, you know, an hour and a half, you know, one way sometimes, and doing that 2 to 3 times a week. And so, you know, nationally, cardiac rehab enrollment is, you know, pretty pitiful. You know, to the tune of about maybe 10% of all people that actually get referred to cardiac rehab actually attend cardiac rehab. You know, and historically, cardiac rehab has been like a center-based program. So, like us, you know, so we're in a metropolitan area, we have a big population here, so that's kind of where we're drawing, which is great if you live in, you know, the 45-mile radius of here. But if you live outside of that, that enrollment really drops. And so we don't have a great option right now for people living rurally. And so legislation has been on the books to support that and kind of make it a permanent, and it's all about reimbursement, right? If we're not gonna get paid for the service, we're probably not gonna wanna deliver the service too. So CMS or the Medicare doesn't currently cover remote cardiac or pulmonary rehab services right now. They did kind of temporarily during COVID because there wasn't a lot of options for anyone then. But then as kind of we resumed in-person services, those kind of temporary things went away. But there's a lot of push to kind of make those things permanent so that we can kind of give some more equality for those people living in rurally, and that would also help improve those enrollment numbers, because some people are just saying no from the sheer fact that they don't live close to any one of the centers.
So you'd go federal, I mean, you know, it's kind of a federal, legislation is what you're looking for.
Yeah, that's where it is right now. There's separate bills in the House and the Senate to kind of push this forward to make it permanent, to where it would be a covered service. And then what that looks like is a little bit variable, but we would probably have something that we're obviously we can't replicate the same things that we're doing here in the center. You know, people don't have a home gym and a walking track and all of those things, right? So it would definitely look different, but it would still provide some sort of kind of monitored education, monitored exercise with education.
And to keep it in the safety realm, you know, in a home setting, would you have a telemetry set up also so that they would be monitored with their heart rate and their, you know, all their vitals? Or?
Well, that's a great question. I'm not sure. Mm-hmm. Like some models kind of risk stratify, and which doesn't make a lot of sense in my mind. But so because they're saying like, well, only people that are low to moderate risk should qualify for virtual. Mm-hmm. Well, then you're saying that people are at high risk should still be the ones driving, you know, 2 hours into the clinic, which, so it still kind of eliminates those. So, but most of the models that I've seen don't involve any sort of telemetry at home.
That would be a wise thing if that could be.
True, but you know, there's a big push, like even in centers like us, because if you've gone through cardiac rehab here or anywhere else, you know, you're probably hooked up to a telemetry monitor. But there's a pretty big push to get people off of those telemetry monitors as soon as possible, because it can kind of create a dependency, right? People think that I'm only going to be safe if I'm on a monitor, which isn't true whatsoever. that monitor is not keeping you safe. It might be giving us some input into that, but and eventually you or everyone else is going to graduate from a cardiac rehab program, and then it's the then what, right? And so there's more of a push to get people off cardiac monitors while they're in cardiac rehab much sooner, so because it could be a pretty abrupt transition from going 36 sessions of monitored and then saying, all right, but now you don't need to.
When I had my heart condition 8 years ago, I guess, I had AFib and I had a couple of ablation procedures. I was not qualified to get cardio rehab because I did not have a stent, I didn't have open heart surgery, I didn't have some of the other things that would put me into cardio. Has that changed?
Not yet. No, I
Are
think
they planning on it? Because it seems that some of the stuff that cardiac rehab does would be very good for people with AFib or people that don't meet those other criteria where they went in and did something, put something in your heart or whatever.
Yeah, you're preaching to the choir, right?
Okay.
We agree. We would love that. It's really about research and money. So there needs to be enough.
And the insurance companies have the
Yeah.
money.
Well, it's less about the commercial insurance companies. It's more about our federal
Right.
ones. So there needs to be research, evidence to support that cardiac rehab, is providing benefits for patients with AFib. We saw a number of years ago, because they do add diagnoses kind of over time. The stent, open heart, and kind of a TAVR, or a heart attack. Those are kind of your bread and butter diagnoses. But then a number of years ago, they did add heart failure to that, because there's great evidence showing that people with heart failure have great outcomes with cardiac rehab. And then they did extend it for a period of time to all patients with heart failure, but right now it's just a subset of patients with heart failure. But then also you got to think about, if they added people with AFib, how many millions of people with AFib are now going to be eligible for cardiac rehab, and then how much money that's going to cost, programs like Medicaid and Medicare and all of the commercial payers too. So they do it as a way to kind of limit that a little bit too.
If somebody has a pacemaker, does that qualify then for it?
No, doesn't either. So the only qualifications for cardiac rehab are MI, so heart attack, so open heart, or some sort of valve procedure, and then a stent. And then stable angina does qualify too. So if you have chest pain but it's stable, that's qualifying. And heart failure, but you have to have a reduced ejection fraction. So those are the diagnoses that qualify.
Is that ejection fraction then something under 50?
It's 35 or less.
Oh, 35.
35. So you have to have what
Really?
we would call systolic heart failure or heart failure reduced ejection fraction.
Interesting.
That was me.
Mm-hmm.
When I first came through, I believe it was 2012,
Mm-hmm.
and heart failure did not qualify at that time
Probably.
because I self-paid
Mm-hmm.
to go through cardiac rehab, but I do know for a fact that it works for heart failure, and because I swear by the doctors in this program, because I wouldn't be here. It made a tremendous difference.
But I know that there is talk about and kind of push to try to get like other diagnoses added to, like AFib, like other sorts of heart failure too, because there's a fair amount of evidence out there showing that it has good benefits too as well too. And we know like AFib, people can get ablations and people can get other things done to control their AFib, but there's a lot of lifestyle factors that influence AFib too.
Part of Mended Hearts program is double. One is communication, but it's also education. Mended Hearts National is trying to develop programs where they can concentrate on at-home support. How do you see Mended Hearts supporting that effort, your effort, with an and-home? By that I mean, let's take that patient over in Weezer. How do both of us work to support that patient road to recovery? Mended Hearts is trying to do a program where if they're supplied with a phone number, they will get a person with supposedly the same type of illness to call that particular individual if the individual wants to be called on a weekly basis. How are you doing? Are you trying this? Is that something that could work with St. Luke's or your institution? Or is it, I guess my question is, how is something like that implemented to help you and us help the patient?
Yeah, I mean, I could see it functioning like that, where, I mean, I think, you know, you get our patients' phone numbers right now and saying, hey, if you're wanting to be contacted, you know, write your phone number here. I could see it kind of functioning something like that, to where you're calling them and then also then maybe asking them like, hey, you know, could I call you on a certain cadence? And then I think like for attendance at these meetings, we've talked about too, like, I mean, we're in the digital age of virtual meetings, right? I mean, it's just kind of just commonplace. I don't even know how I even existed before virtual meetings, so we got anything done. You know, I think you could offer up virtual attendance to those, doing like remote cardiac rehab or living remotely too. So there's not a specific reason why they would need to, you know, physically have to drive down here. I think there's ways that they could attend these meetings as well.
We do a virtual meeting concept now nationally. I guess my question secondly was, how do I relate to that patient in Weezer? Because I've had no contact with that individual. Do I try to get the hospital to furnish the patient that information? Do I try to go to cardiac offices to say this is available to one of your patients? There's a big open area there that I see as not being covered to support the patient's need, because I have no way of knowing who the patient is.
Are you, because you potentially seeing those patients like at the bedside, like what you're doing right now?
Not all of them, because you guys are turning them out so fast, they may have had the operation on Monday and they had somebody there Monday, but by Wednesday when somebody comes back, that patient's gone home already. Or when I went to see the patient the first day, they were sleeping, or the doctor was involved. I know I'm struggling with you here, I'm not trying to do that, but I'm just trying to figure out how I can benefit the individual that doesn't know that I'm available for them.
Well, and Ray, what you're saying is there's a gap. We've got this big gap, and there's a lot of patients in that gap that are not being reached. And I think we're struggling as a group right now to what do we do? Do we go to the doctors? I mean, just like you said, this is something we have really had meetings on and agonized over because we're missing a lot of people.
Yeah, doctors probably aren't going to be your best bet.
Probably
not.
Yeah, probably so.
I mean, it would probably be, I think probably one of your best resources would either be, we have someone, kind of acting as a liaison, kind of talking about cardiac rehab in the hospitals right now. I think working with those individuals so that if you're not able to reach them from a Mended Hearts perspective, they would be able to at least kind of say like, hey, I don't know, I think we've I think we are right now putting the Mended Hearts brochure in our folders right there, but being able to kind of speak to that and say, and maybe, and this is, I'm just kind of throwing out options
that's
here.
right.
We would have to probably have some further talks with them, but like, you know, saying, hey, you know, could you at least kind of give a blurb about Mended Hearts if you are seeing this patient, you know, and whether you see him or not, at least they've had some information. And they could also ask the patient potentially if, you know, would they be okay if Mended Hearts contacted them after hospital discharge too?
Yeah, we could supply you with the card. I'm not trying to take the conversation. We could supply that individual with a, hey, you live over in Weiser, hey, you live over in Baker. We know you can't go to cardiac rehab. If you wish, here's a source that you can follow up with if you like. That's all I'm asking for, is the ability to communicate support. St. Luke's is phenomenal with this. I mean, they allow us to go in and see patients prior to their operation, because there's a lot of people that are very emotionally concerned about the outcome. And basically, just takes somebody who's been there, did it, and that's what I'm driving at for McCall, Stanley, all these other areas. It's we saw 70 or 80 people yesterday here, and we got 20 some odd people that say, I'd like to know more about what you're doing. I know they're out there, and I'm struggling to try to figure out how I can support that effort. That's all. Thank you for what you do.
Well, we got a big problem with HIPAA too, don't we?
That's
probably
that's
the
a little
number
bit of
one.
the concern too. Is, you know, we would probably, you know, that's where I think like working with our inpatient educator so that she could have a conversation. You know, she could at least kind of get consent from the patient, and then you know, she has consent. All right, is it okay if I give this group your phone number so that they could contact you afterwards? At least we have that. Yeah, I have a little probably concern too about cold calling and handing numbers over.
Little paper trail.
Then it's a little bit more of an issue.
So do you have patient educators that come in and talk about cardiac rehab to every patient that gets some kind of a heart?
Yeah.
So is there some way we can get the names and the access to those people that actually are educators?
Yeah, I have one name. Really, because there's one person that does the bulk of the work for Boise and Meridian, and then it's really our team from Cardiac Rehab that is seeing the patients out in Nampa.
Okay.
How do we reach new docs? I mean, this is getting a little off the subject, but I mean, when you're trying to reach patients and these new docs don't have a clue
Yeah.
about cardiac rehab or about Mended Hearts.
And not to downplay this, but
Yeah.
I feel like if you want the biggest bang for your buck, is not going to the docs. They are not the ones that control messaging. It's really the nurses, it's the PAs, it's the medical assistants. They're the ones that have probably much more time. You've been to the doctor before, right? You probably spend more time with the support staff than you do with the physician. So it's really those people. Those are your primary contacts to get to know, because those are the ones that can then influence the docs too as well.
Yeah, good point.
So
So, yeah.
you got to figure out who really has the power
Yeah.
here.
The nurses and the,
Well,
It's the women.
and the EMAs.
I figured that you would, be able to help and guide us, and it's just good to have an input on what's going on in rehab, because we haven't had any communication with you for a while, so
Yeah.
this is really.
Let's see, what else is new though? I mentioned Twin Falls, and so we're actually flipping clinics right now. We have 2 small clinics on there, one for pulmonary and one for cardiac. So we're actually gonna flip-flop the 2, mainly because we feel like doing so. Cardiac is always a bigger volume than pulmonary. That's how it is at all of our sites too, and so doing so will allow for us to kind of grow more in Twin Falls, because the volumes definitely are there, and we're just kind of constrained right now too. One other big thing that's coming hopefully by the end of this year is we'll be implementing a program called Intensive Cardiac Rehab here. The model isn't gonna be significantly different than outwardly. If you looked at the people exercising in the gym, they're gonna do exactly the same thing. What this really kind of allows us, or what we will do as part of it, we'll do a lot more education. So a lot more robust education. So right now, if you've been to cardiac rehab, you're gonna get some very brief education out on the floor, and then maybe go to kind of some consult visits with maybe a one-on-one with a dietitian, or you might go to some small groups from there. But probably the amount of education that you do as a total for 36 sessions in cardiac rehab is not that much. This is gonna greatly expand that. So people will come for exercise, they'll continue to do that. Then they'll actually be coming over here, and we probably need to talk about how that might impact your meeting space too. But every group will come over here for about 30 minutes of education every single session. So much more robust education as part of that, which is really kind of our aim for coming to cardiac rehab, is to hopefully implement lifestyle changes so that people never have to come back to cardiac rehab more than their first time too. So that's hoping to come sometime by the end of this year.
Are you still combining pulmonary with cardiac in your clinic over here?
Yep, yeah.
Okay.
Yeah, so, and that would be our ideal down in Twin Falls. Two small clinics in Twin Falls is not a great efficiency option. So that's our long-term strategy, is to identify a larger site where we could combine both cardiac and pulmonary down there. And it would kind of have the same model as here and Nampa there too. And then going to this kind of, they call it intensive cardiac rehab, it's kind of a Medicare thing. There'll be cooking classes, one of those 3 days a week. So a lot more kind of robust education, cooking classes, pieces to that we're not really capable of doing right now. Those are the big things coming down the pike for us probably.
Any other questions?
And then virtual cardiac rehab. If it could get approved this year, it could get approved next year. So if virtual cardiac rehab is approved, then we need to kind of probably start thinking about how are we going to deliver that? Who are we reaching? What does that look like? But that would definitely expand our program too.
Who all can access it?
Yeah.
Because that would be important. I mean, if I had access to a cardiac rehab, even though I may not be qualified for a cardiac rehab program, but if I could have access to something, that would be helpful to a lot of people.
Mm-hmm.
You'd probably have to hire a staff that would just be strictly for that, would it?
Yeah, I wouldn't envy that staff. So because I think it's going to have to be some sort of rotation, because unless you really love sitting on a computer all day long, that doesn't sound like the most ideal to me. So most models have it's like one person and then a virtual group of about 6 to 10 patients. So where they're doing kind of some sort of group exercise, and it's all video. It has to be kind of two-way, so audio and visual, and then education. And then it would probably be some sort of maybe we would have one of our case managers doing one virtual class and then 2 in-person classes, rather than probably one person doing every single virtual class. That would be a lot, I think. Would not be my cup of tea.
You'd have to direct them through exercises too, wouldn't you?
Yeah.
Yeah.
Mm-hmm. Yeah, it's totally different
yeah.
format, right? It's how do you try to keep an eye on 8 virtual patients at the same time, and make sure that they're following along with the exercises and like
Safe.
using good form and that they're safe. So yeah, it's going to be
Would they have
different, that's for sure.
machines,
What's that?
Would they have machines, or would it just be walking?
More than like, and yeah, if they had access to like a treadmill or a
Right.
recumbent bike, and it might be a little bit different for every single person involved in there. They might not be all doing the same thing, or it might be, leading a group in like, they might all have like resistance bands, right, and leading it that way. So it's going to be it definitely is not going to be the same as a center-based program for sure.
Right.
Yeah, so that could happen any year, and then definitely programs across the country. I mean, there's already virtual kind of programs kind of geared towards this that are kind of saying, hey, we have a package, we already know how to do this, buy our product, and we're the experts in there. So there's a lot of companies chomping at the bit already in that setting.
And I would think you could get help, I don't know, you can correct me if I'm wrong, Ray, but I think you could get help from the International Mended Hearts. In other words, the main office could probably help in terms of legislation, possibly.
They're in Washington DC this week.
Yeah, I mean, that's, if you need help.
Yeah, because I know we have our organization, our national organization, they have like a Day on the Hill event too, to kind of lobby members of Congress on kind of specific issues that are affecting us. I know and virtual cardiac rehab is one of the big ticket items that they're going to be lobbying on.
The Mended Hearts group is constantly looking for people who want to do that. And it takes a special type of professional or an individual to do that, and to want to get in front of their senators and congressmen. But if anybody knows of anybody in this group that would like to get involved, my goodness, let us know. We're really big on that. Every penny we have goes to that, because some administrations want to cut it, some administrations don't. You just have to, what can I say, keep on educating.
Yeah, and we've had some decent interest. Like our cardiology friends are big supporters of our service, and so like we have one of Senator Rish's staffers. He came through, and we kind of gave him the dog and pony show. So hopefully all of that kind of continues to lend support for more services and expansion.
I'm shocked at the number you gave, that 10% is all you get. That's the wrong word. Is all the individuals that are willing to continue with their health. I'm just shocked at that number.
Yeah, and our organization, along with the American Heart Association, has teamed up with I don't know if you're familiar with Million Hearts campaign.
No.
So it's kind of in its second iteration now, but Million Hearts campaign is really kind of this initiative to improve cardiac care.
Okay.
And one of their things is specific to cardiac rehab. So their goal is to increase enrollment into cardiac rehab to 70% or more.
Yeah.
So, which is a pretty lofty goal, being that nationally it's not that great. It's about in the teens right now. So ours is better than that, at least. And they've laid out kind of specific things that each organization can do to improve their enrollment. And we're doing a lot of the things that are on that Million Hearts list. But we know that even if we do all of those things, we're still going to be hampered if there's people out in the rural communities that just can't physically attend one of our center-based programs. So expansion to virtual would definitely help that out.
Thank you.
Yeah, thanks for having me.
Yeah,
I, for one, would like to thank your organization for what they do.
oh yeah.
I talk to a lot of people, and I probably am kind of crazy, but I tell them you're foolish if you don't participate in the cardiac rehab program. And on a scale of 1 to 10, yours is a 10 compared to a lot of other ones in the United States. You do a great job. I'm not saying it to blow smoke at you. Your people are phenomenal. You have a wonderful staff, and you have a staff that seems to care about people, which is very important. And I'm still shocked at 10%. I'm amazed. But thank you very much for enlightening me.
Yeah, for sure. One last plug, and not for Cardiac Rehab. So we are doing the Heart and Vascular Symposium again this year. If any of you attended it last year, this is something that's happened many years in the past for St. Luke's, and then got paused due to COVID for about 3 years, and so we brought it back last year. So it is happening again this year. We changed the date on it a little bit. So it's not in Heart Month anymore, which is this month. So it is now May 2nd, Friday, May 2nd. So
Yesterday, she gave us some information. We're gonna bring it to the board, our next board meeting.
Okay.
Talk about it.
yeah, and then we, like we had last year, you know, if you want a booth there for sure, and
Yeah, we do.
we'll set you up.
Definitely,
Yeah.
definitely.
And different locations, so it won't be at the Anderson Center as it was. It's gonna be at the Central Plaza. So, which, the Morrison Knudsen building. But now known as St. Luke's Central Plaza. So
It's a nice facility.
it is. It's nice. It's actually a little bit bigger than the. Yes.
Much easier.
And then for that event, we'll be live streaming it. People can attend in person in Twin Falls, and we'll be live streaming it down there. And then for this year too, we'll actually be adding a fully virtual component. So people wanted to just access it from the comfort of their own home, we will be doing it, streaming it that way as well too.
How much of the day does this take up? Is it all day or?
Yep, so it's like 8 to 4. Yeah. So, but that way we extended the virtual so people didn't want to come in person, or if they only wanted to be able to attend, 1 or 2 sessions, that enables them to kind of just pop on, view the session, get off.
You gonna have Ray speak again? No.
They don't have time.
No, you did a great job. We just need to spread the love.
Thank you very much.
Yeah, thanks everyone.
Very good.
Thanks, Josh.